Welcome to This Week in Health IT News, where we look at as many stories as we can in 20 minutes or less. It's Tuesday News Day, and here's what we have on tap. House votes to remove federal ban on national patient ID. Amazon launches Personalize, a fully managed AI-powered recommendation service, and CFOs plan a more active role in healthcare digital transformation. My name is Bill Russell, recovering healthcare CIO and creator of This Week in Health IT, a set of podcasts and videos dedicated to developing the next generation of health IT leaders. This podcast is brought to you by Health Lyrics. Every health system needs to do more with less. Start allocating more of your money to innovation and less to daily tasks. We know where to look. Let's talk. Visit healthlyrics.com to schedule your free consultation. Want to support the fastest growing podcast in the health IT space? Here are 5 easy ways to support the show. Number 1, share it with a peer. Number 2, follow our social accounts, LinkedIn, Twitter, YouTube. Interact and repost our social media content. Number 4, send me feedback. I love your feedback. Love your recommendations on news stories, questions, guest recommendations, you name it. Bill at thisweekinhealthit.com. Number 5, subscribe to our newsletter on the website. So let's get to the news. House votes to remove federal ban on national patient ID. I pulled this story from Healthcare Innovation Group, Mark Hagland and Rajiv Leventhal. So on Wednesday, the U.S. House of Representatives passed the amendment that would end the current federal ban on the funding of a national patient ID strategy in an action that was hailed by leaders of Chime. So Leslie Kriegstein is Chime's Vice President of Congressional Affairs. She had this to say: great news. Yesterday evening, the House passed an amendment that would remove a prohibition on funding for a national patient ID strategy. Our members have seen this 20-year prohibition as a barrier to interoperability and a risk to patient safety. And she thanks everyone. Pulled this, Marianne McGee wrote in an article, Healthcare Info Security article, House approves lifting HHS ban on the same topic. Many healthcare and health IT industry groups have long been urging Congress to lift the ban so that the identifier could be used to help match patients and to correct health information from multiple sources to improve care quality and patient safety. But privacy advocates worry that the identifier could lead to an inappropriate exposure of sensitive information. She goes on to say that the bill passed 246 to 178. And she also does a rehash of Schoolhouse Rock. We know how a bill becomes law, but for everyone who's listening, there's still a long way to go for this. The House still needs to approve its appropriations bill. Senate needs to do something similar, and then it needs to get to President Trump's desk, and then he will sign it and make it a funded measure, make it a law, I guess. Nevertheless, Actually, there's some more in this article. Let me just summarize it. Russ Branzell talks about the National Patient ID Challenge in 2016, $1 million crowdsourcing competition that failed, according to him, mostly due to complexity. And Russ is a previous guest on the show. You can check out our conversation together. There's other organizations that hail this: American Health Information Management Association, American Medical Informatics Association, and Chime, amongst others. There's one dissenting view here, and that's the ACLU. The ACLU took an opposing stance to the healthcare groups, stating that the amendment could be interpreted as allowing the development of a national unique health identifier without legislative approval. The ACLU's letter wrote, the dangers of having a system like this compromised or inappropriately used or access to track individuals are profound. I would guess so. And for this reason, the ACLU has historically opposed national ID systems like a national unique health identifier because of the threat they pose to privacy rights. The group also attested that absent strong privacy protections, use of unique health identifiers could empower HHS and potentially other federal agencies, including law enforcement, to gain unprecedented access to sensitive medical information. All right, so that's the lead story for this week, an important movement. Before I comment on the story, I just want to say this is absolutely the right objective. To get a complete longitudinal patient record at the point of care cannot be argued as a worthwhile and an important goal. And Chime is doing exactly what we've asked them to do, which is to move the National Patient ID forward in pursuit of this goal and this objective. And this is something I'm very passionate about. So if this gets a little more passionate than usual, if it comes off as a rant, I apologize. But I really do have three fundamental issues with this approach. And they are, the first is I think it creates a false sense of security or really a false sense of accomplishment. Everyone who's approving of this feels good about themselves. They feel like they've solved a problem, but they really haven't solved anything. They've opened up a funding mechanism to solving the problem, which means we're looking at 5 to 10 years before anything of substance really happens in this space around a national ID. So that's the first thing. I feel like we've created this false sense of accomplishment by getting a national patient ID. I don't think it solves the problem. And why doesn't it solve the problem? Which gets to my second problem, which is I just think it's the wrong solution. A national patient ID is a rabbit trail that doesn't solve the actual problem. The right solution, if you're wondering, is the patient. The patient should have the data. Apple already figured this out. The unique identifier is your telephone number, and when you request the data from your health system gives it to you on your phone, and now your phone number is the unique identifier, and you are the aggregator of the data. We just need systems that allow for that to happen. Get my data delivered to my phone. I can now go to the next health system and give them temporary access to my medical records so that they can use it to care for me. And you know what? They can give it back to me when they're done because I don't really want you to have it. I mean, at worst, you're selling my information either consciously or unconsciously. And most times my data is just sitting there and it's not doing anything. And then the other false narrative here, or the false sense that goes on is because it's in the EHR, some people might look at it and believe it's a complete medical record, and it's never the complete medical record. I should be the aggregator. I am the aggregator. I am the constant at the point of care. Every time there is a point of care, I am the constant. The patient is the constant at the point of care, and that is who should have the data. It shouldn't be the government. It shouldn't be the HIE. It shouldn't be the Health Information Exchange. It shouldn't be the health system. It never should have been. We are horrible aggregators of data. We are horrible sharers of data. So I think Seema Verma and Secretary Azar have this right, and e-patient Dave, for that matter. Give me my damn data. Get it into the hands of the patient. Let me be the aggregator. The other thing that's going to happen as the patient becomes the aggregator is I think you're going to see a whole new set of data brokers that emerge. And this is going to be an ecosystem of data brokers as well as navigators and these organizations are going to have clinicians embedded in them that are going to help me to organize my record. They're going to help me to make sense of my record and to help me make care decisions. There's those in the healthcare community who feel like we can't trust the patients with their health record because that's not exactly the right way to say it. The right way of saying it is the health system, because I really believe the motives are right. And the motives are, I want to protect the patients from themselves. They don't know what to do with the data. Okay, I agree with you. I don't know what to do with my health data. I don't understand my health data. But with that being said, I think I can find a data broker that can help me. And I think that if we start giving the data to the patients, those brokers, those new organizations, that new ecosystem is going to emerge. And they're going to be able to help me to manage that data and to make sense of that data. If you want to put regulations around those brokers to make sure they have my best interest at heart, by all means do that. But what you're doing now, what health systems are doing now, is to continue to propagate a model that is broken. And that is not moving this thing forward. And there's this belief that all these competitive forces are just all of a sudden going to share data once we have a national patient ID. The problem isn't the national patient ID. The problem is the competitive nature of healthcare and the inability for some health systems to share the data based on any number of factors. Be it technical, be it desire to share the data. I had a situation as a CIO. I sat down with another CIO. I was asked to, in our community, to put together a health information exchange strategy for the good of the community. And I sat down with this other CIO, and I said, let's talk about our sharing strategy. And he said, there is no sharing strategy. My organization does not want to share data with your organization. And I'm like, okay, that's the end of that conversation. And you know what? The national ID wouldn't have solved that. Now, that might be dated. That was back in 2013, 2014. Maybe there's enough regulations to push that organization to share data. But I'm not sure that that's that's the case. I think the answer is to get the data in the hands of the patients. But not to be overlooked, let's get to our third item, and that is that the ACLU's warning here about a dystopian future where two things happen. One is we make it really easy for the hackers. We take all the data, we put it in one location, and we tie it up in a little bow. We haven't proven we can secure our data. And then the second thing is, we're not really creative enough. We don't think creatively enough about what nefarious actors are going to do with the data. We think it's country A, B, or C is going to do something with the data, and that's not my concern. And that's really not the ACLU's concern either. The ACLU's concern is that HHS and other federal agencies, and what are they going to do with the data? Think about it. In light of our current political climate, when our political enemies essentially look at the things that you say and determine, I don't like what they say, let's see if I can go into their health record and see what sensitive information I can get from it. And if you don't think that's a possibility, the ACLU thinks it's a possibility, and I think a lot of other people think it's a possibility. I'm really kind of shocked that we think this is the solution, first of all, and then second, I'm really surprised it passed by the majority that it passed. I think people really want to wash their hands of this and say, hey, look, we did a good thing. I think directionally it's the right direction. Getting the complete medical record at the point of care is absolutely the right thing to do. But gosh, I just want us to think it through a little bit more, understand the ramifications, and just allow for a different way of going about this problem. I'm sure people are not going to be happy with this little rant, but I really believe that there's a different model out there with the patient at the center and data brokers and navigators emerging. And I think to a certain extent, we just need to get out of the way and let that emerge. So, if you have a point of view on this, please email me. I'm always open to be proven wrong and to discussing it on a future show. So let's keep going. So Amazon launches Personalize, a fully managed AI-powered recommendation service. So Amazon today announced the general availability of Amazon Personalize, an AWS service that facilitates the development of technology and email marketing systems that suggest products, provide tailored search results, and customize funnels on the fly. It's available in a couple of their data centers, most in the U.S., Tokyo, Singapore, and Ireland as well. And let's see, one more paragraph. Personalize, which was announced last year at Amazon's reInvent conference, is a fully managed service that trains, tunes, and deploys custom machine learning models in the cloud by provisioning the necessary infrastructure and managing things like data processing, feature extraction, algorithm training, and optimization and hosting. Customers provide an activity stream from their apps and websites, e.g. Clicks, page views, signups, and purchases, in addition to an inventory of the items they want to recommend, such as articles, products, videos, music, etc., optional demographics, and other stuff, and they receive results via an API and only pay for what they use, one of the promises of cloud computing. I just wanted to share this story because I think it's an important service, and it's an important example of these kinds of services that are going to continue to be available to the organizations that figure out how to get their data to the cloud in a secure fashion and start to interact with the APIs that are available in these services. I don't think health systems are going to develop this, nor do I think they should. I think that, and I don't think you're going to get some off-the-shelf solutions on this. I think the cloud models are going to be the primary delivery mechanism for these kinds of services. I think this is an exciting service. I am hopeful that some enterprising health IT organizations make a little magic with this service. And at that's one aspect. I think there's an opportunity for a startup to maybe get ahead of the curve on this, think through it. It's not really about suggesting an article or product or video or music, although it might be within healthcare. I mean, to suggest articles, that would be powerful in and of itself. Suggest products, that would be powerful in and of itself. Suggest classes and training. And I mean, there's a whole host of ways this could go. I hope, again, somebody within health IT organization has enough bandwidth to make something happen. But also, I think there's a startup opportunity here for some enterprising, smart, talented machine learning kind of person. So there it is, AI-powered recommendation service ready to go. So have at it. Hope some exciting things happen. Our next story. So, intense hospital consolidation increases patient costs. This is from Alana Moriarty, Definitive Healthcare blog. So, Definitive Healthcare is really about selling a service. So, from the blog, I really pulled this out because the numbers are interesting. So, I'll share a couple of the numbers with you. Cost reduction is arguably a primary driver for mergers and acquisitions. Interestingly, mergers may benefit the acquired facilities more than the buyer. That's probably pretty obvious. A report from NCCI Insights, acquired hospitals reported a reduction in operating costs of between 15 and 30% through economies of scale. As you would imagine, reducing your supply chain, labor, other big costs within that realm. So mergers and acquisitions reduce the need for out-of-network referrals, keeping patients and payments in network. So that's a lot of the drivers of what's going on. However, lower operating costs do not always equal lower prices for patients receiving hospital services. The same NCCI report claimed hospital mergers increased the average price of hospital services by 6 to 18%. Additionally, an analysis of 25 metropolitan areas with high consolidation rates showed that average price of a hospital stay increased by 11 to 54%. 11 to 54%, that's a lot. According to a study commissioned by the New York Times, of the 19 metropolitan areas highlighted in the graphic from the report, only 5 showed a decrease in the cost of average hospital stay. It goes on to say, according to a 2015 study, hospital mergers may increase the likelihood of intensive surgery without improving patient outcomes. This is a contrast to another study from 2017, which reported 30-day readmit rates for heart attack, heart failure, and pneumonia all dropped by about 1%. In addition, studies have shown that competition in the healthcare market actually has a positive effect for patients, particularly in areas such as care access and mortality rates. So, it's I love the numbers, but here's the reality. You really have, it's such a nuanced deal. Healthcare pricing is such a nuanced deal. I think you have to dig a little deeper. Did the prices go up 11 to 54%? Apples to apples, or is it the increasing cost of the specialty drugs that are coming out to combat cancer and other chronic conditions? Is it the specialty drugs that are driving the pricing? Is it labor that's driving the cost? I mean, it's really hard to say how much of that 11 to 54% increase was due to the actual M&A activity. But the reality is, first of all, I'm kind of struck. It's like, who would have thought that reducing competition increases cost? Well, I don't know. Any high school student that had an economics class, I think, would know the answer to that question. I think the second thing is, I think the thing I want to point out to people within healthcare right now is you guys are heroes. You're doing great work, and you're going to take a lot of shots over the next year and a half. And you're going to take shots from both parties, anybody who's involved in an election, statewide elections, national elections. You're going to take a shots because healthcare is going to come under the microscope, and you're going to hear story after story. In fact, there's one story I'm not even doing this time about liens on homes. And these stories are going to be elevated. They're going to talk about how evil healthcare is and how they're not doing good things. And I want to bring this up now to say next year and a half is going to be tough. You guys are still heroes. You're doing very challenging, difficult work. It's a very complex industry, and not all of the cost levers are really in your hands. So there's a lot of work to do. There's some things need to be done around obviously pharma pricing and those kind of things. Understand the work that they're doing. Understand the value of the drugs that they're bringing to market. But at the end of the day, that has to get reined in. If it doesn't get reined in, every dollar you save in healthcare is just going to be eaten up by those specialty drugs. It's just a reality of the thing. So again, very complex, multifaceted issue. Let's go on to the next story. So patients say physicians with mobile apps are faster, convenient, offer better communication. Healthcare IT News, Nathan Eddy. So this is another one of those. Really? No kidding. Mobile people like their mobile apps. They think it's faster, convenient, offer better communication. Let me give you some of the details. This is a chief finding of a survey: 550 U.S. consumers commissioned by mobile device management specialist SOTI. I wish the N was a little higher than 550, but it's enough. It's enough. It gives us good feedback. So the survey also found more than half of the U.S. physicians, 57%, offer their patients a mobile app to do tasks like schedule appointments, access personal health care information, and view lab results. More revealing was the fact that 3/4 of the patients surveyed said physicians who integrate mobile technology are able to provide faster, more convenient experience. 54% of survey respondents said that they thought physicians who leverage mobile technology cut down on physician wait times. In addition, the survey results revealed 57% of respondents prefer communication with physicians and office staff through mobile apps as opposed to calling the doctor's office. Wow. So the reality is, I'm not telling you anything you don't already know. We all know this. We know it's right. So I only point out this story to really help you to bolster your case with the laggards. There's going to be laggards within your health system, and these kinds of numbers are helpful. If these numbers don't work in your market, maybe you can conduct your own study. I think these numbers will bear out. It's just, we know it's true, right? We know that I would rather in some cases I would rather text. I know for a fact that I would rather schedule my appointment online through an app than making an actual phone call. So on the off chance that you're still dealing with some laggards, I thought I'd throw that story in as a little help for you. Let's go to the next one. Healthcare hiring continues to slide in May. This is Tara Banow, Modern Healthcare. And suffice it to say, last month's healthcare hiring, 15,700 new jobs, was the weakest since September of 2017. May saw 42% fewer hires than in April and 69% fewer than in March, according to the U.S. Bureau of Labor Statistics. Majority of the new hiring was in ambulatory, as you would imagine, physician offices also, and dentist offices and other things. The outpatient care centers added just 200 jobs, and other ambulatory healthcare services lost 500 jobs. So, again, I believe the reason I pulled this story out, healthcare is hunkering down. Budgets are going to continue to come under scrutiny. The smart healthcare IT organizations are really, getting ahead of this. They're building out sophisticated models to track and justify their expenses, their run versus grow, and this is probably a tough time to be asking for more staff. You need to be considering how you are going to do more with less. So, at a minimum, redirecting money from your daily run to the grow. So, since we're on the topic of money, let's go to the last story and talk about CFOs, right? So. The last story comes from, again, Nathan Eddy, Healthcare IT News. CFOs plan to a more active role in healthcare digital transformation. Black Book survey nearly 1,600 hospitals, and healthcare CFOs are going to be more active. What are they going to be active doing? So let me just summarize this. They're going to be active in updating their ERP solutions. Their ERP solutions are woefully behind the times. They're going to redirect money from EHR implementations as they go to more optimization, and they're going to start to try to redirect the money to the ERP solutions. Nearly 8 in 10 of the health system CFOs surveyed said that they plan to increase their investment in digital transformation by the end of 2020, with nearly 70% predicting an increase of more than 20% by the end of the first quarter. So, the vast majority, 90% of the CFOs surveyed, said they expect to be more active in the implementation of transformational software and services in 2020, with few, and they talk about there's not that many proven cases, and so they're gonna become more heavily involved. So pull this out. A couple reasons. One is just to note that money is moving. That money that the CFOs are starting to look at this and say, hey, you know what? We spend a lot of money on the clinical transactional systems, but we have not spent time on the customer service and financial systems, and even supply chain for that matter. So a lot more money. They want to start directing money into those areas which have been neglected over the years. I think the other thing the other thing worth noting here is, here's a sentence, CFOs indicated that until now they had been content to let the chief information officers pursue this issue. So there's a certain sense in which the CFOs are starting to stand up and say, hey, I want to be more involved. I'm not just going to hand this over just because it's a technology project to the CIO. I think we should embrace that. I think that is that's a good thing. As we know, less and less of these projects are about the technology. More and more of these projects are about getting them operationally implemented. If the CFO is willing to step to the table and start to become a part of that, by all means, you're welcome to come in, because the operational changes that need to happen within the health system can only really happen when those operational leaders are at the table and making it happen. So, you know what? That's all for this week. So this past week, we had Eric Yablanca on the show to discuss architecture and healthcare IT. We're quickly approaching our 100th episode, and we are planning something special for that. So please stay tuned. In 2 weeks, I'm excited to do a show with Jefferson Health CEO, Dr. Stephen Klasko, and CIO Nasser Nizami in an interview in Philadelphia. For those of you who have been following the show for a long time, I think I mentioned on show number 4 that I would love to have Stephen Klasko on the show, and Nasser was kind enough to make that happen. So looking forward to that. I want to thank everyone for your comments, news, suggestions. If you want to contribute, just continue to drop me a line at hello@thisweekinhealthit.com. This show is a production of This Week in Health IT. For more great content, you can check out our website at thisweekinhealthit.com or the YouTube channel at thisweekinhealthit.com/video. Thanks for listening. That's all for now.